All right, guys, welcome back for another lecture over the skull, chapter 11. We're going to finish up the skull portion of chapter 11, and then next week we'll move into a couple other portions of the facial bones. So for today, there's the projections we're going to cover are special projections or trauma projections that are done with the skull in case any of the other normal routine projections cannot be obtained. So let me bring up the PowerPoint here. All right, here we go. So again, there are objectives, right? Just kind of a review over the landmarks that you should make sure that you know where they're at and how to find them on the patient because they are going to be important for when we're positioning. We talked about the interpupillary line, the supraorbital groove, superciliary ridge, the angles of the mandible, the acanthion, the nasion, and the glabella. So those are, again, important landmarks that you need to know for positioning. Just again, lateral view of the same landmarks that we talked about. Remember the portions of the orbit. You have the supraorbital margin, which is up top, the infraorbital margin, which is on the bottom, and the mid-lateral orbital margin, which is in the middle. So remember the infraorbital margin going to the EAM is our IOML. The one going from the middle of the eye to the ear is the OML. So just remember those. All right, again, our positioning lines, all very important. Make sure you know them. Make sure you know how to figure out where they are so that way you can see if they're perpendicular or parallel to whatever image receptor or CR that we need it to be to. One thing I wanted to mention for the IOML is that it does have a secondary name, Reed's baseline. So you may see it called Reed's baseline, but it's just referring to the IOML. So make sure you know that. All right, so now we get into the position of the cranium. So these are the special projections we're going to talk about today: the PA axial Haas method, AP 0-degree trauma, and the AP axial 15-degree to reverse Caldwell. It's done for trauma. So I know we normally do a Caldwell as a PA projection, but this one is trauma, so it's going to be done as an AP. A cross-table lateral trauma, and then an AP axial 30-degree trauma. Very similar to our normal AP axial that we do. Of course, if it's trauma and they're in a C collar, they're not going to be able to flex the neck. So that's the only difference there. I have put the page numbers for the trauma projections, which are located in chapter 15. So if you need to go back and reference those, you can. The PA axial Haas is in chapter 11. That's on page 418 if you need to refer back to that one. Okay. So first one is the PA axial Haas method. Now this projection does kind of replace the AP axial Town method. So if the patient cannot flex the neck enough to do the AP axial Town, or they cannot lay on their back for some reason, then the PA axial Haas will take the place of that Town projection. So it's going to best project best visualize the occipital bone. And then when we look at the radiograph, just like we do for the Town, we want to make sure that the dorsum sellae is located within the foramen magnum. Okay. So this projection here, 80 to 90 kVp, 40-inch SID. Place the patient prone. Put the mid-sagittal plane to the middle of the image receptor, middle of the table. You're going to rest the nose and forehead on the table. So remember, for all PA projections of the skull, right? Any PA projection of the skull that we do, the proper positioning for that patient is to put the nose and forehead on the image receptor, because then that will bring the OML perpendicular to the image receptor. Okay, so rest the nose and forehead, bring the OML perpendicular. Flex the neck, again, bring that OML perpendicular, no rotation or tilt of the head. So again, get to the edge of the bed on the patient, right? And look at the head and make sure that it's not rotated or tilted, okay? And that's the best way you're gonna be able to tell if it's rotated or tilted until you get to the radiograph. Once you've done all that, right, we're gonna make sure that we have our CR angled 25 degrees cephalad to the OML. Now for the AP axial, it was 30 degrees caudal to the OML. This one is going to be 25 degrees cephalad to the OML. Because remember, anytime you reverse projection, going from AP to PA or PA to AP, you're going to reverse the angle, the direction of the angle. So before we were going caudal, this time we're going to go cephalad. But Please make note that the angle has changed to 25 degrees. Okay. We're going to center along that mid-sagittal plane. Okay, you want it to pass through the EAM, right? So if I draw a line here, it's passing through the EAM, right? Exiting 1.5 inches superior to the nasion, right? So the nasion is there. Whoops, didn't mean to do that. We're going about 1.5 inches above that nasion. Okay, so again, look for the crosshair on the table, right? Because we have a crosshair that's going to come this way on the table, right? There's the crosshair. We want that crosshair to go through our CR centering point. So just open up that collimation field, see where that line is going, and put it through our centering point. All right, erase that. All right, collimate and suspend respiration. All right, and that's it. All right, it is an alternative to the apiaxial town. So when we look at the radiograph, we still want to see the same structures we saw for the apiaxial town. Okay, so biggest differences here, it's a PA projection rather than an AP, and it's 25 degrees cephalid to the OML rather than 30 degrees caudal to the OML. Okay. Here it is, right? And this is what we want to see here. Okay. You see the dorsum sellae, which is this structure right in there, right? Within the foramen magnum. That's what we want to see. All right. If you have that in there, then the angle was correct. The flexion of the neck was enough. Now, we also need to check for rotation, right? And rotation, we're going to check these structures here, Petrus ridges. If they look symmetrical and look almost the same size on each side, then there's no rotation, right? If one looks bigger than the other, then you have some rotation going on there. The occipital bone, which is back here, right, is going to be magnified just because it's further away from the image receptor. So just know that this projection does take the place of the, or can replace the town projection, but it's not the best projection because it's going to place the occipital bone too far away from the image receptor. Now, going back to the dorsum sellae within the foramen magnum. So remember, if we see this dorsum sellae projected superior to the foramen magnum, two things happen, right? Well, there's one ultimate thing that happened, and that means that the angle between the CR and the OML was not enough, which means you didn't accomplish a 25-degree angle between the CR and the OML for this house projection. So two things can happen because if you don't have enough angle. Either you didn't angle enough, right, under angulation, right? The other thing is excessive extension. I'm sorry, excessive extension, yeah. So if you have excessive extension, right, it pushes that OML back towards the CR, and you have a decrease in the angle between the CR and the OML, okay? So remember, anytime the dorsum sellae is projected superior to the foramen magnum, that means that the angle between the CR and the OML was less than what it should be, right? Less than 25 degrees. It either was because the CR was underangled or because you had excessive extension or insufficient flexion, okay? Now, if you see this dorsum sellae projected low, right, and being superimposed by the posterior arch of C1, well, then the error there was too much angle between the CR and OML, right? So you have over 25 degrees. The way that can happen, and I hope you're writing all this down, right? Pause it if you need to, go back, right? Make sure you write it down, right? So if the angle between the CR and the OML is over 25 degrees, the dorsum sellae goes inferior to the foramen magnum. Now, if that happens, right, again, you either angled too much or you had excessive flexion, right, and you need to extend the head a little bit. All right, so again, too much angle or too much flexion. All right. Okay, so that was the PA axial Hawes projection. Now let's talk about the 0-degree trauma skull. Now this one here is on page, what page did I tell you? I think it was like 590. 590, yeah, 590 exactly. So if you look on page 590, you'll see that they kind of combine the AP 0-degree and the AP reverse Caldwell together on the same page because the positioning is the same. The only thing you're going to change is the angle, okay, and the centering point. So for this projection here, the AP 0-degree trauma skull, the patient is going to come in as a trauma patient, can't flex their neck, maybe in a C-collar. So you need to make sure that you don't try to adjust the patient's neck or take off the C-collar unless you get authorization from a physician. We're not supposed to go in there and just take off the C-collar because you could cause more damage. So most of the time you're going to do it with just the C-collar on. So this projection here, we are looking for fractures of the frontal bone. It's still going to project the frontal bone the best, but mainly any type of fracture in the skull. KVP is 80 to 90, 40-inch SID. Patient is going to be supine, right? They're going to be aligned mid-sagittal to the table. Remember, in the book, it says to see the warning. Remember, and the warning just tells you that if there's suspected cervical fractures, do not try to move the head or flex the head until everything's been ruled out. Okay, now, patient is laying on the table. Obviously, they're not going to be able to flex their head to bring the OML perpendicular. But remember, in order for you to have a good AP 0 degree, right, we want to be able to see the petrous ridges within the entire orbits, okay? Now, that's going to happen if the CR is parallel to the OML, right? And that's parallel, those two lines. If the CR is parallel to the OML, ridges, let me make that better. Ridges fill the orbits. All right. So what we need to try to do is the patient is not going to be able to get the OML perpendicular to the image receptor. So we're going to have to try to adjust the CR to the OML. Okay. So what you're going to want to do is you're going to want to angle the CR till it becomes parallel with the OML. So if I'm going to draw on the picture here, here's the OML, right? The CR needs to match that angle of the OML. It needs to be parallel with it. Normally, your CR would be like this, right? Straight down. But we're going to have to angle it a little bit to get it parallel with the OML. Normally, it's going to be about 10 to 15 degrees caught at, but that does vary with each patient. So you just have to make sure that you visualize the OML and then get that CR parallel to it. Okay, so angle your tube a little bit, caudal, to make sure that you're parallel with the OML. Now, the centering point is still going to be to the glabella, just like we did for a PA 0 degree. So we still want to center at the glabella between the eyebrows, all right? Along that mid-sagittal plane, collimate, suspend respiration. All right. When you collimate, make sure you include the vertex of the head, which is the top of the head. Now, we don't necessarily need all of the mandible, okay? But you need to make sure you get at least the vertex. All right. So when we look at the projection for this skull, right, we're going to notice that we still want to visualize the frontal bone, right? And in order for it to be a correct AP 0 degree, we need to make sure that those ridges fill the entire orbit, right? And they do. Pretty close. The ridges are up there, right, on each side, right? So we want to make sure that they fill the orbit. They could have been a little bit higher, okay? But they are within the entire orbit. We want to make sure there's no rotation, no tilt, right? For tilt, we're going to check that mid-sagittal plane, right? If it's going this way or that way, then we have tilt. Right, rotation, we want to check the distance from the side of the eye to the side of the head, right? If it's about the same size, same distance on each side, then there's no rotation. Remember, if one side gets bigger than the other, so if this is my left side and this is my right side, if the left side gets bigger, right, if this distance gets bigger, right, what happened? Well, that means that the face was rotated towards the opposite side. The face was rotated towards the right. So whichever side gets bigger, the face is rotated towards the other side. All right. Now, again, we need to talk about where the ridges go within the orbit, and if it's too high, too low, what happened? Okay. So again, remember and keep this kind of as a guideline. If the CR is parallel to the OML, right? There's no angle between them. It's parallel. The ridges fill the entire orbit. Okay. Now, as you increase angle between the CR and the OML, the ridges start moving down. Okay, so more angle, they will get lower and lower within the orbits and eventually move out of the orbits below them. Okay, so 0 degree angle within the orbits. As the angle increases between the CR and the OML, they move lower and lower within the orbits. Okay. Now, if you decrease the angle, they move higher and higher, right? So that's one way to tell if you how to fix your or to correct your radiograph if the ridges are high or low. The other way is to know if you need more flexion or extension. Okay, so one good way, and I'm going to stop this share so you can see my face. One good, and I kind of told you I was in the lab, right? Here are my Petrus ridges, right? They're located within the middle of the skull, but they kind of project through the orbits. Now, if my ridges are too low, right, then that means I had too much extension of the head, right? If I flex correctly for my AP 0 degree, the ridges should be within my entire orbit, okay? If they're too low, that means I had too much extension, right? The more you extend, the lower they go in the orbits. So in order to correct that, I need to flex the head more to bring them up higher. So if they're too high, there's too much flexion, and I need to extend a little bit. If they're too low, I extended too much, and I need to flex more. Okay, so that kind of help you to remember or to know what to do whenever you have the ridges not in the correct place. All right. But again, AP 0 degree, you want to make sure that the CR is parallel to the OML. Okay, so no angle on here. We're just going to make it parallel to the OML. I'm sorry, there is going to be an angle because obviously you have to get it parallel to the OML. But no angle between the CR and the OML. Okay. And of course, optimal exposure factors, whenever you see that, I'm looking for sharp lines and bony trabecular markings. All right, and if y'all don't know what the bony trabecular markings are, they're the little striations you see within the bone. So if you see the little lines within the bone, those are bony trabecular markings. All right. Next projection is the AP axial 15-degree reverse Caldwell. This is on the same page, page 590. Position is the same, right? Because we have the patient as a trauma. They're going to be on their back, C collar on. Patient, the head's in the same area, right? So what we're going to do is we're going to leave the patient as is, right? And we're going to look at the OML, right? So we see the OML here. It's got a little bit of an angle. It's not perpendicular to the image receptor. That's okay. Now remember, what makes a Caldwell a Caldwell? Well, it's a 15-degree angle between the CR and the OML, all right? If it's more than 15 or less than 15, it's no longer a Caldwell, okay? It's just an AP axial. But if it's a Caldwell projection, it's the relationship between the CR and the OML of 15 degrees. And we know that for a Caldwell projection, where should the ridges be projected? They're going to be projected in the lower 1/3 of the orbit. That's what makes a Caldwell, okay? So for this projection here, look at the patient's OML. And we're going to go 15 degrees from the OML caudal. I'm sorry, cephalic. Okay, so towards the head. So if you notice here, right, and it's kind of hard to visualize because you're like, well, the CR looks like it's perpendicular to the IR, which it probably kind of is. But if I was to draw out, I'm going to try to draw it as straight as I can, this OML, right, that OML is drawn out, right? If I was to bring my CR and make it parallel to the OML, then I need to go 15 degrees cephalid from that OML, right? So this angle between there and there is 15 degrees. So I started my CR parallel to the OML, right? So I started my CR parallel to the OML, and then I went 15 degrees from that OML cephalic. And that's why it looks like the CR is perpendicular, but it's really 15 degrees cephalid from the OML, and that's what we want, okay? You need a center to the nasion along the mid-sagittal plane, right? So it should be centered there, right? And then you're going to suspend respiration. Make sure you collimate, include the vertex, suspend respiration. Okay. So again, what makes it a Caldwell? Erase that. Can't erase that. What makes it a Caldwell? It's the 15-degree angle between the CR and the OML. All right. Now remember, when we're looking at a Caldwell projection, right down here, we want to make sure that we see the ridges in the lower 1/3. Okay. That means we had a proper amount of angle between the CR and the OML, 15 degrees. If there's too much angle between the CR and the OML, those ridges go down. If there's not enough angle, the ridges will go up towards the top of the orbit. All right. So if we look at the image here, right, ideally, you want them up a little bit higher, right? Because if we were to divide these orbits into thirds, right? We want those ridges up a little bit higher, right? So what does that tell you when you look at this image? If the ridges are too low, right, what does that tell you? Right? Two errors could have happened, right? And think about it for a minute. I'm gonna let you take a couple seconds to think about it before I tell you, right? What are the two errors that occurred that could cause those ridges to go lower? All right. Well, first thing you have to remember, you have to realize is that the angle between the CR and the OML was more than 15 degrees if those ridges are too low. Okay. So there was too much angle. Or, right, what else could cause the ridges to go low? Too much extension. All right. So it's going to be the same whether it's AP or PA, right? Either the way that the CR and the angle between the CR and the OML works, it's either way AP or PA. Either there's too much angle, they go low. Too much extension, they go low. Not enough angle, right? If it's less than 15 degrees, they go up. If there's too much flexion, they go up. Okay. All right. And then you just want to compare the 0 degree to the 15 degree. Remember, 0, fill the entire orbit, 15 degree, lower 1/3. We still check for rotation the same way on both, the distance from the lateral orbital margin to the lateral cranial cortex. If it's the same distance, there's no rotation, right? If my right side over here gets bigger, what happened? Where was the rotation? Rotation was to the opposite side. It went to the left. Okay. All right, let's compare all three. All right, so we have and again, this 30 degree PA, just kind of going back to our normal PA projections, right? We wouldn't really do the 30 degree for a trauma projection. We're really only looking for the Caldwell and the PA. But just as a review for what we had before, remember the more the angle, the lower the ridges go. If it's no angle, they're within the entire orbit. 15 degree Caldwell, they're in the lower 1/3. All right, those are the three things you need to know. Okay. Now let's talk about the 30 degree apiaxial town projection. All right. Let's see. All right, so for this 30 degree town, we are again looking for the normal things we would normally look for an apiaxial town that's not trauma. Looking at the occipital bone, dorsum celli within the foramen magnum, those type of things, right? But this is just done if the patient cannot flex the head. KVPs 80 to 90, 40-inch SID. Put the patient supine, right? Remove all the objects from the head area, right? Align the mid-sagittal plane to the middle of the table like you see there. And again, the warnings, right, that always come with trauma patients is to make sure that you don't flex or extend the head unnecessarily without first making sure that there is no fracture of the cervical vertebra. Now, for a town projection, right, when we normally do a town projection, we try to get the OML perpendicular, right? We flex the head, try to get the OML. If you can't, then you can use the IOML. With this patient, we're not going to be able to do anything. So we need to just make sure that we see where the OML is, right? And we're going to adjust our CR based on that OML, right? For a normal town projection, you need a 30 degree angle between the CR and the OML. So you get that CR to become parallel with the with the OML, and then you're going to angle 30 degrees caudal from that parallel OML. All right, so this here would be 30 degrees, right? And that's where you want to, that's how you're going to angle your tube, right? Get it parallel with the OML and then go 30 degrees more from that OML. Okay, we're still going to center to pass midway between the EAMs, which means we're going to try to center still at that 2.5 inches above the glabella, but for some reason the book says to center 6 centimeters above the superciliary arch. I don't know why they do that, but that's where they're saying to center. Okay, so you're going to look for that superciliary arch, which is kind of where the eyebrow is, right? And you want to go 6 centimeters above that, which I know is basically the same area as the 2.5 inches above the glabella. I don't know why they do that, but you have to kind of know that you have to know the difference, right? So for a normal town projection, 2.5 inches above the glabella. For the trauma town projection, 6 centimeters above the superciliary arch. All right. Collimate, suspend respiration. Now, if you can't use, if you don't use the OML, right, we still can use the IOML, right, which means that you would become parallel to that and then go 37 degrees from that. So it's still 30 degrees from the OML or 37 degrees from the IOML. All right. Now there is an issue if the OML is too extended and your angle is going to be more than 45 degrees. All right. There's going to be an issue with that because you don't want it to exceed 45 degrees. So what that means, let me show you because it gets kind of complicated. So normally your CR comes like this, right? It's perpendicular to the image receptor, right? So let's say that the OML extends out, right? Let's say the OML is 20 degrees from the perpendicular, right? Well, we know when we do the trauma projection of the town, we want it to be 30 degrees from the OML. So our CR is already 20 degrees from perpendicular. And then we need to angle another 30 degrees. Well, if you add those two angles up, right, 30 plus 20, what do you get? You get 50 degrees. You don't want it to exceed 45 degrees because then you get really bad distortion and the image is not any good. Okay, so if that's the case, then what you would do is you would just go to a maximum of 45. So instead of going to 30, you would just go to 25. Okay, so just remember, the total CR angle cannot exceed 45 degrees. Okay, we still want it to be 30 degrees from the OML, but we don't want it to be more than more than 50 degrees total, which means that we would have to have this OML from the CR be at least 15 degrees because then we could angle our full 30 degrees and still it would only be 45 degrees. All right, hope that makes sense. But just remember, important thing is it cannot exceed 45 degrees. Okay. All right. So again, collimate, suspend respiration, make sure you include the vertex. So what should we see on the radiograph? Well, the same thing we've seen on all town projections. The occipital bone back there, right? And then we also want to see the dorsum sellae within the foramen magnum. All right, we want to make sure there's no rotation by checking those Petrus ridges. If they're the same on each side, then there's no rotation. And then we pay attention to the dorsum sellae within the foramen magnum. If the dorsum sellae is too high, right, remember that there is not enough angle between the CR and the OML. It was less than 30 degrees. So what do you need to do? You need to either increase the angle between the CR and the OML, or you need to increase the sorry. So either you need to increase the angle, right, between the CR and the OML, or you need to increase the flexion of the patient. Okay. Now, obviously, we can't increase flexion, so we would increase angle. Now, the problem you get with trying to increase the angle is you cannot exceed what degrees? 45 degrees. Right? If you go over that, image is no good. So if, say you could only angle 25 degrees instead of 30, you're going to see this dorsum sellae projected superior. That's all you can do, right? Nothing else you can do about that. Ideally, though, you want to see it in the middle of the dorsum sellae. Now, what if you see it too low, right? Again, too low means that you have too much angle between the CR and the OML, okay? And that happens when you have either too much flexion, right? Or just too much angle of the CR. All right. So those, again, are things you're going to have to remember, especially for these AP projections of the town and then like the PA projections. You're going to have to remember, well, if something happens, you know, why did that happen? Okay, so one thing I can kind of share with you is that, again, here is my OML, right? My patient's laying down, right? So if I had my skull, here's my AP, right? They're laying down on their head. So just keep that in mind. They're laying down on their head. Here's the OML, right, from the patient. All right. So I'm gonna try to hold this all in place. There's the OML of the patient. Now my CR is coming, you know, 30 degrees caudal from the OML. Now remember, anytime you see the dorsum sellae projected superior to the foramen magnum or above the foramen magnum, that means that there was not enough angle between the CR and the OML, which is the black pin. Okay, so two things can happen: either I didn't angle enough, okay, or what can cause that OML to come back towards the CR. Right? If I extend the head too much, what happens? The distance between the OML and the CR has decreased the angle. If I need to, then I would need to flex the head more to bring that 30-degree angle between the CR and the OML. If you see the dorsum sellae projected below the foramen magnum, that means you had too much angle. Either you were angled too much with your CR, or your head was flexed too much, right? Insufficient extension. You need to extend it more. All right, so that hopefully will try to kind of help you visualize what happens when you extend or flex the head too much, and then how to fix it, okay? So let me go back to this. All right, and then of course, optimal exposure factors, sharp lines, bony trabecular markings. Okay. Last projection here is the lateral skull trauma. This is probably the easiest of them, right? Because all you got to do is just leave the patient laying down, and we're going to do a lateral projection, which means we're going to try to get a side view of all of the skull. KVP 75 to 85, 40-inch SID. Again, you're going to be supine in a C-collar. Do not try to flex or extend the head. Now, you can try to elevate the bottom of the skull a little bit, just so the bottom of the skull doesn't get, or the back of the skull where the occipital bone doesn't get clipped off on your image receptor. Either that or you're going to have to put the image receptor a little bit lower below the table. That way it doesn't get, you got to put that image receptor down below the table. That way you don't clip off the occipital bone. Now, get the head in a true lateral position. Remember, there's 4 things we need to look at for a true lateral, right? Number 1 is the IPL. Whoops, that's a P, not an R. IPL is perpendicular to the image receptor. Number 2 is the mid-sagittal plane is parallel to the IR. 3, IOML perpendicular to the front edge of the IR. And then number 4, the GAL is parallel to the front edge of the IR. Those 4 things will make sure that you have a true lateral true lateral position with no flexion, no excessive flexion or extension, no rotation, no tilt. Okay. So the IPL is, if I was to draw an imaginary line across the eyes, right, that line would be perpendicular to the image receptor. That's the IPL. Okay. The mid-sagittal plane, again, is that line that goes this way, that plane, right? And that plane extends down. So if there was a plane like that in the body, that plane would be parallel to that image receptor, the same line. Okay. Then you have the IOML perpendicular to the front edge, right? So what that means is that if I was to draw the line from the bottom of the orbit, from the bottom of the orbit to the ear, right? That line there should be perpendicular to this front edge. Okay. I know it's difficult to imagine, but if I was to extend this plane out from the front edge of the image receptor, this line would be perpendicular to it. All right. And then the last one is the GAL, which is the line that goes in the front there. That should be parallel to that front edge of the image receptor. All right. All of that will help you be in a true lateral position, will help avoid excessive flexion or extension or tilt or rotation of the head. Okay. Now, once you've done all that and you get all these things to get a true lateral, right, the CR is going to be horizontal and perpendicular to the IR, right? So again, we do have a horizontal beam, right, and it's going to be perpendicular to the image receptor. We still want to center the same spot that we do for any other lateral skull projection, normal skull projection, 2 inches superior to the EAM. So find the EAM and go 2 inches superior, and that's where you want to center. All right. Now remember, that is for normal skull morphologies, right? If we have a longer or wider skull, then you need to center midway between the glabella and the external occipital protuberance, or the bump in the back of the head. Okay. That is on page 591. All right. I'm sorry, not 591. 589. Sorry, 589. So again, make sure that you're centered correctly. Make sure you include all of the skull, including the vertex and the occipital bone. Make sure you're in a true lateral position, and you're going to suspend respiration on this projection. Okay. And that should do it for our last projection, lateral skull. All right. Here's what it looks like. Again, the entire skull visualized. Make sure you get the vertex and everything. We want to make sure that we don't see any rotation or tilt, right? Those are the biggest things we look for, rotation and tilt. Now for rotation, again, we look at the mandibular rami. All right, so that structure right in there is what we're looking at. So if you see one line, then there's no rotation. But remember, what type of separation are we going to see if there's rotation? Anterior, posterior separation. So you'll see one structure go forward, one structure go back. That means you have separation. That means that there's rotation. Okay. So if the mandibular rami are together, then there's no rotation. If you see separation, then there is rotation. That is the first structure you should look at for rotation. Okay, first structure. Now for tilt, we want to see what type of separation. Right, superior, inferior separation. And the first structure we're going to look at is the orbital roof or orbital plate. See how there's one nice white line there, one line. That means that they're superimposed, there's no tilt. If you see one go up and one go down, then you have tilt, okay? Now, there are other structures we can use to help us, right? One is the greater wings of the sphenoid, which are right there, right? And you'll see one line there and one line there, right? Kind of difficult to see, I'll erase that, but look where my red lines were, right? Those are the greater wings of the sphenoid. There's a little bit of anterior, posterior separation. So what does that tell you? Rotation, right? So that's one structure you can use, and you can also use it for tilt, for rotation and tilt. The sella turcica, which is right here, okay? You see the back part, the dorsum sellae? You see how it's kind of getting into one line in the front there and then one line in the back? That tells you again that there is some rotation, all right? So the dorsum sellae can be used for rotation and tilt as well. And the last one would be the EAM, which is hard to see, but it'd be a hole over here, right? So we saw one hole, no rotation, no tilt. What if I saw this? So one hole in front, one hole in back. What does that tell me? If you said rotation, you are correct. Now, what if you see this? Oh, hold on. What if you see this? Tilt, right? Okay, so you got rotation, you got tilt. But what if you see that? Okay, not only do you have rotation, but you also have tilt, right? So the EAM, the sella turcica, and the greater wings of the sphenoid can be used for both rotation and tilt, okay? They are a little bit harder to see. So the primary structure you should look for tilt is the orbital roof or orbital plate. And the primary structure you should look for rotation is the mandibular rami, okay? Now also we want to make sure we have the correct amount of extension and flexion on the skull, right? And these are where those IOML and all that come into play, right? So if my EAM is here, and I was to draw a line from there to there, that is my IOML. That needs to be, remember, perpendicular to the front edge of the image receptor, okay? That'll make sure you don't have excessive extension or excessive flexion, okay? Also, the GAL, which goes right here from the maxilla to the frontal bone, that line needs to be parallel to the front edge of the image receptor. And again, will help with too much flexion or extension, okay? And those look pretty good. All right, and of course, optimal exposure factors, sharp lines, bony trabecular markings, okay? So make sure you don't see any blurry lines. All right, we don't have any radiographs for critique, it's just a single question in here, but what type of CR angle is required for a PA axial Haas method projection of the skull? Give you a few seconds to answer, think about it. Now remember, this takes the place of the town, all right? But it is not the town, it's a PA axial projection of the skull. If you said A, 25 degrees cephalad, you are correct, right? So remember, it's not 30, it's 25, and it's cephalad, not caudal, All right. Now, if it's a normal town projection with the OML perpendicular, it would be B. If this is the OML perpendicular. And this one would be if the IOML is perpendicular, and both of these are AP projections. Okay. This one here is the angle we use for a Caldwell, and that is a PA projection. Okay. All right, guys. Well, that I think will do it. This was a little short one. It wasn't too much because we kind of gone over some of this stuff already. So if you have any questions, or if you need to go over anything, please email me. We will be in the lab next week doing these projections. So make sure you kind of look over them in the book. And remember, most of these are going to be in chapter 15. I put the page numbers there for you. So make sure you look in chapter 15 for those trauma projections. And then the one Haas projection is in chapter 11. All right, guys, well, that's all I have for you. If you have any questions, concerns, please email me, and I will see you all again. Thank you.